Checking all the technology just to make sure it's all working. Right, well, I think it looks pretty much, I think we're all here, everybody that's expected. Do you think everybody's here, Kwame, from your list? Yeah. Okay. Well, we'll kick off as it's 10 o'clock. Good morning, everybody, and welcome to our board in public today. I'd also like to welcome, we have a patient story later, and we have Eleanor Shield, our advanced nurse practitioner for enhanced recovery, presenting, and also Mr. Barry Keeler, our consultant colorectal surgeon. So welcome to you both as well, and obviously welcome to governors and any members of the public that might be attending as well. Apologies for absence. I know Ian Reckless.
Ian and Terry.
And Terry. Oh yes,
and Karen is standing in for Terry. So.
Lovely. Okay, thanks, Karen. Oh yes, I did see you come up. So thanks for stepping in today. Any declarations of interest for noting? Hader?
Thanks, Alison. I'd like to register that I've joined the board of the MHRA as an associate non-exec. I don't believe there's any conflict of interest, but worth registering.
Thank you very much. Thanks. And any other conflicts of interest for the items on the agenda today at all? No? Okay, thank you very much. Any matters arising? I didn't spot any, but if colleagues can point out any that we might have missed? No? Great, that's lovely. Okay, and then going on to my verbal report. Just to say, since my last update, I mean, I've carried on with all the usual meetings. Visited Woughton Parish, basically looking at their community hub there. They do an amazing service with free food supplies, supporting the vulnerable and isolated in that area. It's well worth a visit if anybody would like to. I've met with Hannah O'Neill, who's the new chair of the Urgent Care Centre, and I'm arranging a visit to go and meet staff as well. So I'm looking forward to that. And Joe and I have met with the Bedfordshire Hospital Trust, our counterparts David Carter and Simon Linnell, and we're arranging regular meetings there as well. I've taken part in Living Our Values programme, Values in Action and Leading with Values, and I'd highly recommend that to anybody who would like to do that as well. It's well worth it. It's a really different approach to get a positive and open culture in the organisation. And I'm going to recommend as well that governors might want to do the training as well. I think it would be very positive. I've carried on with the Freedom to Speak Up, continuing my involvement with that. And in October, it's Freedom to Speak Up month. So I would encourage everybody to take part in that. And we're also organising, hopefully, lots of staff taking pledges and advertising that. So do keep an eye out for all the adverts for that coming up. I'm getting to know more about the work of the hospital charity through Vanessa Holmes, and I'm hoping to meet many people involved in the charity, some donating, obviously, and those taking part. I recently met with some Freemasons who have made huge contributions to the organisation over the years, and particularly through the pandemic. And I know they've done quite a lot of work recently in the garden at the Cancer Centre. So they have a tremendous input, and obviously I'm looking forward to meeting others that contribute as well. I attended the Health Watch AGM, which was online, and I mean, it was amazing how much work they managed to do during the pandemic period and managing to engage with people and to get feedback and people's views. So I'm looking forward again to working further with them. And with the integrated care system, work continues on establishing the governance system, putting something in place that will have an emphasis on local partnerships and integration. And next week we have the Board Development Day, and looking forward to that with colleagues, to certainly for those of us that have joined sort of during pandemic period, be an opportunity actually to meet up face to face with everybody and have some really good discussions, I hope. Okay, and that's really my update unless there are any questions. Okay, thank you very much. Okay, Joe, handing over to you.
Thank you very much, Chair. I'll start with the current pressures on the organisation, if I may. We have continued to see a significant step increase in the number of patients coming into all parts of our organisation, and I know that Emma will talk a little bit more about that in our performance report. But just to sort of set the scene for that, in the first 5 months of this year, we normally see about 80,000 outpatient referrals in the first 5 months. We've seen over 90,000 come through in that first 5 months of this year. So these are not trivial numbers of additional patients being referred into us, and we've seen those increases across maternity, the emergency department, and so on. So it's an organisation that is under significant pressure. We are doing everything that we can, as always, to ensure that we look after our patients safely and effectively, and we are trying all sorts of different innovative and appropriate ways of managing patients to try and ensure we can cope with that significant increase in demand. But the board needs to be aware that it is, unlike sort of winter or other pressures that we've had as an organisation in previous years, this is across every particular aspect of activity within our organisation. And not surprisingly, again, that's also impacting on staffing. And what we're seeing, I think, for the first time here is that despite enhanced rates for bank staff to come and work here and do extra shifts, I think the general NHS population is extremely tired, and I'm delighted on the one hand to say that a number of individuals have managed to take a break over the summer. What that has meant is that we haven't been able to have our usual reliance on bank staff to fill vacant shifts. So we'll come on to talk about that a bit later on throughout the board, but I thought I would start with that because that is probably the most sort of pressing agenda. Let's move upwards from there. We had a very good session with the CQC, with our ITU and the critical care team, and the feedback from the CQC on that has been superb. They were very impressed with the team, the work that they're doing, and that will come back sort of formally as part of a response from them, I'm sure. But that was lovely to hear, given all of the pressures that critical care have been under over the last sort of 18 months. So it's pleasing to say that. You may or may not be aware that we should be aware that we've been implementing a new food menu and a new way of delivering and distributing food to our wards and our inpatients. We've had some very positive feedback from patients on that, and we have also, which is great for our green agenda, seen food waste drop from around about 18% down to 2%. So a really, again, significant positive, in this case, step change in what's happening with food in our organisation, and congratulations to everybody that's been involved in that. You may be aware that Milton Keynes has been accepting a number of Afghanistan refugees. We have played our part in the system in supporting the council who are leading on this, and healthcare services more broadly, to look after the needs of those refugees as they settle into the hotels and come out of some of the national quarantine hotels. So we've been very closely involved in the council and other partners across health and care, and I think that again shows the strength of the working relationships and the relationships that we have more broadly across Milton Keynes, which is very positive. Couple of other things to highlight. I didn't mention COVID specifically in the update, but it's fair to say that our COVID numbers continue to be higher than we would like or indeed would have expected at this time. And So we have got just over a ward's worth of patients in our organisation. And whilst that might not seem a lot in terms of actual numbers, clearly you will be aware that it does mean that we have to ensure separate pathways for patients who have COVID-like symptoms and who have identified COVID, and all of that equates to an overall reduction in the capacity that we have available within our organisation. So it's another pressure point for the organisation on top of all of those extra patients that we're being asked to see and look after. Final couple of things from me, and then I'll shut up. John is going to talk about the Cancer Macmillan quality scores when we come to the Cancer Centre. Well worth staying tuned in if you're a member of the public or anybody else not normally on the board to hear about that. That's very positive. We've had nearly 600 nominations for our staff awards. So despite all of the pressures, despite everything that individuals and teams have had to deliver, I'm delighted to say that people have taken the time, have taken the opportunity to put people and teams forward for staff awards, which is lovely to hear. You may have heard on the national news that there is a blood bottle shortage. That shortage continues. We are managing it locally and again across the health and care system. We have not run out. We are following the national guidelines and we are coping at the moment. And then last but by no means least, we completed phase C of our eCare rollout, which brought paediatrics, theatres, anaesthetics and critical care onto paperless records. And not surprisingly, given the expertise and the excellence of the teams involved, that went pretty much without a glitch. So we are pretty much paperless now across our whole inpatient footprint, and we are now focused on outpatients to finally get to a totally paperless hospital. So we are doing, as always, remarkably well on the digital agenda. I'll draw breath and hand back to Alison if there are any questions.
Thank you very much. Any questions at all? Helen.
So thank you for the update, and I just want to say well done for all the still really positive things that continue to happen despite the pressures. I just wanted to ask about COVID and the impact, and is it still does that affect staffing? Have we seen an increase in staffing numbers? And I equally wanted to ask around, is there any particular area or age group that is being affected by the COVID patients we're seeing admitted, i.e. like maternity, pregnant mums, that sort of thing? And finally, is it people that are immunised, not immunised, and are we seeing a severe COVID illness as we were previously with the number of patients we've got?
Thanks, Helen. I'll bring Danielle in shortly, and then Nikki, and Danielle around staffing and Nikki around the sort of COVID patients themselves. So I think it stops you having to listen to my voice constantly. So Danielle, do you want to come in on staffing absences?
Yeah, thanks, Joe. So we've been monitoring the staffing absence in relation to COVID, in part because we now have a process in place where if people have a test because they've been pinged by track and trace, they can come back to work more quickly. So we have seen the absence from people in relation to COVID drop off. We've got about 30 people who are isolating, so between 30 and 40 who are off every day for COVID related reasons. But we have seen good success with the test people and then bring them back. So in the best case, they're off for maybe 24 to 48 hours, depending on what time they got pinged and had their test. But in the worst case, they're off for the full isolation period. So it's not nowhere near as bad as it was originally. And the new systems for bringing people back is working well.
And Danielle, just on top of that, I think it's worth saying that we're in the high 90s in terms of staff vaccinations, which is a very positive figure across the NHS. Nikki, do you want to give a bit more detail on the COVID situation in terms of patients and vaccinations?
Yes, thank you, Joe. Yes, Helen. So I think it's an evolving picture, as we know. We did have a cluster of pregnant women that were tested, that were admitted with COVID, that were quite unwell. We've done a significant piece of work with the local Maternity Voices partnership. We've made a video, the head of midwifery and her team, and that has really helped increase vaccinations, because we know that when professional groups support women to have vaccinations, the uptake is much better. I would say that a high proportion of our patients admitted with COVID are not vaccinated. And so we've had quite a number of young people that have been admitted. And when I say young, I take myself into that category. So 40s, 50s. So I don't mean like children that haven't been vaccinated. And actually what we're seeing now in the last few weeks, people that have been vaccinated but that have got comorbidities and complexity that were probably vaccinated in January, because we're about to go into a booster round, aren't we, with the flu? So that's sort of the picture that's evolving currently. And it does give a challenge for our intensive care unit, because we've got to split that into a green pathway, a non-COVID pathway, and a COVID. So that is quite complex. And we do have a significant amount of patients that are non-invasive ventilation that are on our COVID ward. So we've got a COVID ward, but it's not completely full because of the acuity there. So yes, it's an evolving picture. And I think the thing that we've got to think going forward, now schools are back, are about children as well. So obviously there's a concern that nationally that there's going to be a peak, and there's lots of planning around flu and COVID going forward and how we might manage that. But that's the current picture, Helen. Thank
you, Paul.
Thanks, Helen. Thanks, everybody. Andrew.
Thanks, Allison. Joe, I think you did a really good job of presenting a picture of the hospital under pressure, with the demand being higher and the capacity being reduced by the different processes we have to follow because of the pandemic. And you mentioned that you were doing everything we could to make sure we look after the safety and well-being of patients. It's clearly something has to give, you'd think, because we know that we spent many years trying to optimize in the old world before the pandemic, and now there isn't loads of low-hanging fruit to optimize still further with this. So what do you see as being the trade-offs that the executive team have been forced to make? And in the past we've talked about, and the obvious one strike me as being about patient experience and waiting time. What's the, I know Ian isn't here, but what are we doing in relation to the extent it is waiting times? And I know it must be waiting times are one of the things that give. How are we managing trying to minimize the harm that is incurred by people who have to wait? And then Helen mentioned it, I think the staffing point you made is also incredibly well made. I can't imagine how tired some of the staff feel, and how relentless it must feel, and how that can be a little bit overwhelming. And we all know it's more difficult to raise your game when you're up against pressures. It makes it even more fatiguing. So I'm curious as to what choices we're making to balance all those immense pressures. And I know they're not easy.
Could I have a sports question? Yeah, you're right. So if we start with the trade-offs piece, as always, unfortunately, the valve that tends to give first is the most routine elective patients, those waiting for the most basic of operations that aren't life-threatening and not time critical. And what we've seen over the last couple of months is both the total number of patients on our waiting list and the total length of time on our waiting list for patients going up. And that is despite everybody doing their best and despite running extra clinics and so on. So the trade-off is invariably that. And when we look at what we're planning over the next 6 months, there are lots of different things that we are trying around both using capacity in the private sector, using ring fence capacity, and as important as those first two, using different ways of engaging and looking after our patients, be that through the digital work that Jackie is leading on around virtual outpatient appointments and so on. So you mentioned low-hanging fruit. I think we are the first to say that there are still a number of things within our control that we can improve on around efficiency and effectiveness. And Barry and the team will come on to talk about the use of the surgical robot and how that's improved length of stay and so on. So we're absolutely not saying there's nothing more that we can do as a team. There is, and unfortunately, the elective waiting time is normally the valve that goes. Your point about the team here is absolutely critical, and we recognise as an executive that despite the reputation that we have now as an organisation that does focus on health and well-being through the work that Danielle has been leading on and Kate on the flexible working and so on, we need to continue to up our game to make sure that we not only keep and look after the people that we have here, but also attract new talent into the organisation. And so we, only yesterday, as an example, doing a question and answer session for the organisation, as you probably know that we do every week. One of the things that came out very loud and clear was, can we do more for training and education? Keep people fresh, keep developing people into different roles. Yesterday at clinical board that Nikki was chairing, there was a whole debate with the senior clinical leadership team of the organisation about how do we develop people in different roles. We know we can't knit more doctors and nurses overnight, but we can develop training protocols, training courses, educational courses that enable different clinical skills to get picked up and different professional skills to get picked up by people to make their working life better, more interesting, and to attract and retain people here. So that for us, if we look after our workforce, if we look after the team here, we stand every chance of being able to do the very best for our patients when they come into us. It's a really fine balance between accepting that patient experience declines because of pressure that we're under. My hope and expectation is that every member of the team here will treat every patient, their family or carer, with the respect and dignity that they deserve, even if they have been waiting longer than they wanted to. So I think we have to challenge ourselves not to allow the experience of our patients to decline in times even though we're under pressure.
Thank you. Hayden.
Thanks, Alison. And thank you, Joe, for the really comprehensive update. I mean, I think my colleagues have touched on the really important bits, and it sounds like supporting our staff is pretty much the most important thing we could do at the moment to really address some of the key problems. I just wanted to highlight some of the good stuff that you mentioned. I was especially heartened to hear about the reduction in food waste. Things like that are much less important, but nevertheless really important, and it's really great to see we're making such amazing progress there. And I can't not mention the phase C rollout, because I've been watching the emails and comms with that with great interest. And firstly, there's been some really great communication. I've loved the engaging style of the emails. That probably really helps inform people and facilitates the smooth rollout. And it's great to see that the rollout went really well, and there were really minor things that went wrong. I think so many times you only hear about IT when it goes wrong, and rollouts are the time when things do go wrong for good reasons. There are lots of complex things happening at the same time. So huge congratulations to the whole organisation, and I really look forward to seeing the benefits of a fully paperless system.
Thanks, Hader. Just if I may, Chair, just come in as well. You're right. There are so many good things going on. Talking to John only yesterday about the fact that, you know, our green initiative with the photovoltaic panels, the solar panels, we've now saved enough trees over the last couple of months to cover the whole of the hospital site already. And it's that sort of thing that we can't just focus on one issue. There's so many things that we can do better, we must do better, and the team here are doing a great job. And so thank you, I appreciate you highlighting that.
Thank you both. I've just got Luke and then Nikki, and then we'll have to move on. Luke.
Thanks, Alison. Jay, thanks for a great update, really interesting. I had a specific question really about kind of the indirect effect of COVID on some of our kind of specialty areas, and specifically around paediatrics. And there's a real concern around the indirect effect that COVID's had on kind of immunity and respiratory infections in paediatrics. I just wondered how we were faring within the paediatric department, and if we've got plans going into winter about how we'll cope with that.
Thanks, Luke. I'll bring Emma in a second, if I may. It's interesting that you raised that, because we had a specific conversation at the management board trust executive group only yesterday with women's and children's and medicine about balancing these pressures. But Emma, do you want to say where the planning has got to on that?
Thanks, Joe. Yes, so clearly we had notation that we expected a larger than normal activity increase in paediatrics, and that's come particularly early this year. At the moment, we in our planning have one ward that tends to fluctuate between adult medicine and paediatric medicine as escalation capacity, and a number of us are sitting down over the next week to go through those plans. We need both activity levels to be sustained and have escalation capacity for both. So that planning is going into, and I suspect it will be quite radical compared to what we've seen in previous years about some of the moves we may need to make in order to ensure ourselves that we've got safe staffing areas for the increase in the adult side as well as the paediatrics. So in terms of almost a perfect storm, we're within the paediatric capacity at the moment, but we anticipate it will need more. And maternity clearly has been under pressure as well in that group of services that are managed by that division. So it's been a tough challenge to do that, but we continue to revise what we're doing, how we're doing it, look at what the guidance is, and make the best possible plans going forward.
Thanks, Jay. Thanks, Emma. Good to hear.
Thank you both. Nikki.
Thank you, Chair. It was just really to go back to staff. So just to quantify a little bit around the fatigue. So it's just the awareness, really. I think we've been in such a unique position with the pandemic that many of our staff are quite traumatised, and not necessarily about what happened at work, but I think there's a homework piece here. And I think a big part of recovery from that is listening. So I think when the non-execs directors are back in the organisation, I think staff really welcome the exec directors going and talking to them in their department and listening to them. I think that's part of it. They want to talk through their story. They want to talk through what's happened to them. I think they all recognise that we don't just have loads of staff everywhere that we can bring in, but I think it's allowing them to have platforms to have discussion, and the Q&A is a classic example of where we did that during the COVID, which was rapid communication to them, but it really is quite fascinating the things that they ask and having direct contact, I think. But it's just, I just wanted to recognise that there is trauma and vicarious trauma from what has happened during the pandemic for staff. Thank you.
Thanks very much, Nikki. I know colleagues are looking forward to getting back into the organisation. I think, Luke, you've already had a visit in, haven't you? So yeah, we're beginning to pick up again. So we look forward to that, and definitely, yeah, we do want to hear back from staff. Okay, you may have spotted a deliberate mistake. I've just looked at my agenda and I think I scooted over the minutes, which we need to approve. I was so keen to get to Joe's update. That's what it was. So just to go back on that, colleagues, just to say, has anybody got I won't go through page by page, but are there any omissions or anything that anybody needs to pick up? So we're all happy to approve those. Good stuff. Okay, thank you very much. And now we're coming to the patient story. Nikki, you first.
Thank you very much. So I'm delighted to welcome Barry Keeler and Eleanor Shield, who are going to do a presentation around the patient experience for a patient that's undergone robotic surgery. We've made a significant investment as a trust board into this new model, and so I think we wanted to bring back a patient experience side of that. So if I could ask Barry and Eleanor to come on and talk through their presentation, please. I can see they're on, but
you can see me.
I can see flashing. I suspect they're dipping in and out to clinical, I suspect. Are you there, Barry, Eleanor?
They're on mute at the moment and having difficulty with it.
You might be on mute. There you go.
Right, can you hear us?
We can hear you.
Sorry, we're having a bit of a technology. I seem to have ended up in a computer with no camera.
Oh, okay.
Right. Thank you, Barry. Okay.
Well, we can see you, if that's any consolation.
Yeah.
Good. Okay, I'm just going to share my screen. Okay, can you see that?
Yes.
Right, starting. So my name is... Right, so my name's Eleanor Shield. I'm the enhanced recovery nurse here at Milton Keynes Hospital. I care for patients who are undergoing elective colorectal and also urology surgery. Okay, so what I wanted to do today was just take you through a patient's story regarding robotic surgery, a patient who's had robotic surgery. Okay, I think you've had a presentation recently about the robot here at Milton Keynes, but this is a bit of an update, but more from a patient perspective. Okay, so these are the robots that a lot of us in Milton Keynes are familiar with. Okay, they were introduced in March 2020. They're well known, a regular site, and apparently they bring you wine now. Okay, this is the robot at Milton Keynes Hospital. Okay, this is our Versius robot. It was introduced in November 2019. We had a little bit of a pause during the first wave of the COVID pandemic, but otherwise it's been operating steadily throughout. I've had a little update. Are you seeing this as a slideshow or are you seeing it as individual?
We're on slide 4 at the moment, Eleanor.
Okay, fine. Okay. So these are up to the 6th of September this year. These are the numbers of cases that we've done within Milton Keynes Hospital. So 89 patients have had colorectal surgery, and that's over 2 operating teams and 2 lists. We've done 68 gynecology procedures. General surgery is 54, so that's things like hernia repairs. And we've just recently done our first abdominal wall reconstruction using the Versius robot, which is fantastic. Okay, so I'd like to talk to you about this lady, Victoria. Okay, Victoria is a 66-year-old lady who lives with her husband, and she has 2 young adopted children. I've met with Victoria and I've spoken to her about her experience, and she was very happy for me to share her details with the board today. I have changed her name, but otherwise everything else is totally her story. She came to us through the bowel cancer screening programme and was found to have a cancer in her ascending colon. And for anybody who's not familiar with bowel surgery, it's a little diagram there as to, you can see where the ascending colon is. So she came and met with Mr. Keeler in the outpatient department and the colorectal cancer nurse, and there they talked to her about her diagnosis, and then talked to her about the planned treatment, which was surgery, and the use of the Versius robot. She was booked for surgery, and She attended pre-assessment where they did a thorough assessment of her past medical history and her observations and blood tests. I saw her myself and I counselled her into what to expect really when she came in, what she can expect from us and also what we sort of expect from her. It's very much shared care between us and the patient, certainly with the enhanced recovery programme. And she came in and had a robotically assisted right hemicolectomy, and she followed the enhanced recovery programme throughout. Okay, so we talked to Victoria about her experience, and we used some emotional sort of keywords, and I'm hoping they will come through. I'm so sorry. Okay, so she was actually unaware of the fact that we did robotic surgery here. Some patients I've spoken to have been fully aware and they've seen it in the local press, but there are some patients that don't know that we do robotic surgery here. So she was quite surprised. She did, however, say that she felt supported with the colorectal cancer nurses and with Mr. Keeler, and she felt well informed. She had a lot of information given to her. She felt quite comfortable with the decision to use the robot. It was explained to her the benefits, and I'll go through those in a little while. And she felt that she received excellent communication around all of her planned treatment. She said to me that she trusted Mr. Keeler and all of the team that she'd met. Okay, so the day of surgery came, I talked about her feelings. On the day of her surgery, she felt relieved. Excited was a word she used, and she just wanted it done as quickly as possible. She really wanted to get home to her family, understandably. So on the day of, before she'd come in for surgery, this consultant had talked to her about the possibility of needing to extend the surgery if they weren't able to do it as a keyhole operation. She had had previous surgery. She had had a laparoscopic sterilisation, and this increases the risk of having to convert the operation to a more invasive procedure. She didn't really mind about that. She just wanted it done as quickly as possible, and you know, however the surgeon needs to do it, she was happy with that. We then talked about her recovery after surgery. So she felt her recovery was really good, and I asked her what she meant by really good. We used appreciative inquiry to explore that in a bit more detail. She felt it was good because it was uncomplicated. She had good pain relief, and she felt everything had gone according to the information that she'd been given, really. She was up and about the next day. So on the enhanced recovery programme, the patients will see physiotherapists twice a day. And she was up and walking and sitting out in her chair the next day. As per enhanced recovery, she was offered breakfast the morning after, and we built her diet up over a period of a few days. She did, her only negative was that she was sick and she had a bit of an accident in her bed, but it was well managed by the staff, and even though she was very embarrassed, she felt they were all very kind and supportive. And she went home after 5 days. There was a possibility that she could have gone home a little bit earlier, but some of her blood tests, her inflammatory markers were slightly elevated. So I think we were erring on the side of caution and kept her in for an extra day or two. But sort of mobility wise and pain relief wise, she was ready to go home perhaps a little bit earlier. And she was very impressed with her wounds. They were very small and they've healed beautifully. Okay, so the benefits of robotic surgery for Allison. Okay, so she had the robotic surgery. Obviously, this is a minimally invasive. As is mentioned before, because she'd had previous surgery, she'd had a slightly higher chance of having to be converted to an open procedure. But thankfully, with the robot, this wasn't necessary, and she had it fully robotically assisted. So good cancer surgery. So this really means that using the robot, they're able to get to be what's the word I'm looking for? To be more sure of obtaining clear margins, which means removing a cancer in its entirety. They get a better lymph node harvest. So when they do surgery for cancer, they like to get as many lymph nodes out as possible and examine those. And that tells us really, gives us an idea of how invasive the cancer is and leads us to direct further treatment such as chemotherapy. And the surgeons feel that that's a lot easier using the robot. It's easier access and they get a better view. So it's you know, benefits for them, benefits for the patient. Faster recovery. So this is because it's keyhole, it's less traumatic than open surgery. It's, to be honest, there's less pressure on the abdomen and on the internal organs, so the patients recover much faster. That, together with the enhanced recovery program, they work really well together. As a result of her quick recovery, she was able to go home better. She was in a much better place psychologically and emotionally, and it meant that she could actually start the next phase of her treatment quickly. So that was the chemotherapy. So she was well enough and recovered enough to start that within sort of 5 to 6 weeks. Somebody who has an open procedure might need to wait a few weeks longer, and really looking at maximum time to starting treatment of 12 weeks. So the quicker we can start it, the better. So she was in a good place, and I met with her recently, and she was undergoing her chemotherapy, and she was in a really good place. She was happy to be back at home with her family, looking after her small children. And then, using appreciative inquiry, we asked her about her overall thoughts on having surgery using the robot. We gave her a selection of pictures to choose from to see if she could summarise what her experience was. They don't really particularly mean anything, but it's really interesting that she chose the one on the left. So that is sunlight through trees in a wood. She felt that she was calm and quiet after having her surgery. It was all happened quite quickly. It was all over, and she felt calm. Her husband, who I saw at the same time, was a little bit more literal, and he chose the image on the right, which is a key in a lock, because it was keyhole. Oh, have I lost my slides? No, there we go. Okay.
They're still there.
Yeah, fine, thank you. Trying to find the next slide. I can get to the next one. There we go. Right, so the future. So there's two ways of looking at this. From a nursing point of view, I would like to perhaps develop a bit more in the way of patient information. I think it would be great to have a dedicated hospital internet page to the robot intranet, and have patient feedback on that. So people who are coming in who don't really have any knowledge of it can access that from home and look at patient stories and feedback, and have a little bit more information on what it involves. As I said earlier, we've expanded into abdominal wall reconstruction, which is fantastic, and there's the potential to expand into other specialities as well, such as urology in the future. And it's our patients love it. They're very positive about it, and they feel very special. So it's definitely the way forward, and this is happening regularly every week now with robotic surgery. It's becoming the norm. And really that's the end of my presentation. I'm sorry it was a bit technologically lacking, but I hope I got across the patient's story and their satisfaction with the service they received.
Thanks, Eleanor. No, you were great, actually. I have to say, I wouldn't even attempt the technology at the moment. I need some education around it, I have to say. Fantastic presentation. I mean, it's extraordinary, and it's the coming to visit the robotic surgeries is one on my list of visits around the hospital. I can't wait to come and see actually.
Oh,
but I have to say, there's somebody's. I mean, I've spent quite a number of years working in the mental health field as well, and what comes through so strongly from your presentation is this fantastic, the physical health side, but also the mental health and well-being. I think that is just such a good example of those two sides of health care. Really working well together. That's absolutely brilliant. So I won't rattle on too much, but you can probably tell I'm very excited. It's amazing stuff. So, but I better let hands are going up, so I better let people come in. Joe.
Thank you, Chair, and Eleanor, thank you very much for presenting. A couple of points to make, if I may. So Eleanor asked me a question on my weekly Q&A a little while ago. About how do we expand the enhanced nurse practitioners in the organisation, and there's some work going on through the nursing team at the moment to be able to do that. So I want to give that feedback to Eleanor. But it's an interesting observation about how anybody can ask any question about what's going on with their service, and we follow it up. Second thing to say is I've had direct feedback from the Secretary of State about his visit here and his exposure to the surgical robotics team and the work that was going on. And he to quote, he continues to bang on about it relentlessly as innovation that should be spread across the NHS. So again, it's one of those things where MKUH is sort of leading the way, and we talk about it as it's the norm almost. And then the final thing, I'm absolutely delighted that Anna brought out the health and well-being of the patients. I think that we shouldn't underestimate the attraction that the robotic surgery has brought for members of the team to come and work at MKUH as well. So it has got us on the map. So Eleanor, you did a great job. So thank you very much.
Thank you. Hader.
Thanks, Alison, and yes, Eleanor, my thanks too. That was an amazing presentation. And pictures speak 1,000 words, and to link her experience to that picture, I think just says amazing things. So a really great story. Thank you. I just had a really minor thought on the use of the term robotic. If I was told I was going in for robotic surgery, then there would be a slight concern. I'd be like, well, have you tested this thing, or whatever it is, right? You can suddenly have other thoughts. Whereas if we highlighted the robotic assisted surgery, or even a phrase which I've come across recently, cobots, meaning robots that help you do your job rather than take over your job, essentially, then that might alleviate some concern. Just a thought.
I think it's made very clear to patients when they come to clinic that it is robotic assisted surgery, and the surgeon is in full control at all times, and the robot doesn't do anything without the surgeon say so, as it were.
Brilliant.
It's not just, we don't just press a button and let it get on with the surgery. So that's made very clear to patients in clinic before they come in.
Fabulous. Thank you.
Thanks very much. I think with so many films around actually these days, that have sort of robots doing something artificially on their own, you can imagine why people would sort of get a weird idea possibly. Nikki McLeod.
Thank you. That was really interesting. Thank you. I'm so pleased that it's kind of been taken so well. But just kind of following on a bit from Hader, I just wondered, have you had much sort of negative feedback from patients, or like really, should we call them, more wilder concerns? I would have just thought, the very much older population might be really, really, really nervous, and whether you've got, much pushback from them.
I think some of them, again, in clinic, it all goes back to communication in clinic. They see the consultant surgeon who talks through how the robot works and how long we've been using it for and what we use it for. They also then spend time with the colorectal cancer nurses separately after that appointment, and they can then go through in more detail what they can expect when they come in. And I think the fact that the surgeon will then explain to them if it's not possible for whatever reason to continue as a robotic assisted procedure, then they will then switch to the traditional keyhole and even the open if necessary. So I think the patients are very much reassured that they will have the safest procedure for them.
Yeah, that's very
sense.
Yeah, thank you.
Thanks very much. And finally, Kate.
Thank you. I just wanted to thank you, Ellen. I thought that was a really great presentation, and I think one of the really striking things about the work that Eleanor and the team do is the holistic nature of the care they provide and the multidisciplinary input. And actually, it's a really wonderful example of how all the professions and skills and talents and experience come together to make a really great patient experience. And I think it's not, it's not dependent on one element of the team or the robot itself, or it's all of the care wrapped around it, and they do a really phenomenal job, and it's really impressive.
Yeah, and I think probably not made clear in the presentation. It's an absolute team effort. There's lots of people involved, and it all makes sure that it runs as smoothly as we can possibly do it.
That's great. Thank you very much, and thank you again, Eleanor. That was it's amazing, and it really is. It's quite inspiring actually to see how things are moving forward, and great stuff that it's that multidisciplinary team working. I think it's fantastic. So thanks for your time this morning. I'm sure you've got a busy day ahead.
Yeah, thank you very much. Thanks for having me.
Okay, see you soon, hopefully.
Bye-bye. Bye.
Bye. Colleagues, I realise we're running a bit over time, so we'll get back onto the agenda, and we've got the nursing staff updates next. Nikki.
Thank you, Chair. Apologies, I think they were doing their presentation in the middle of doing a round, so I think that's why we had a little bit of a thing at the start. Right, so this is the nursing and midwifery staffing report. So I'll take it as read. I think I just wanted to highlight a few things. That you will see that we've got an increase in band 5s and 6s. This is related to the previous work that I've brought to the board, where we've made a change in the model of nursing on the ward, where there's band 6 on each shift. So we inevitably, that has created some more with internal candidates being successful. It's created more band 5s, and I'm currently reviewing this alongside Danielle to look at whether we need to do some international recruitment, and we need to do a review of that. So we're looking at that currently. Maternity, I've specifically put maternity on because we were awarded some monies for Ockenden from the Ockenden review. So we've got 13 whole-time equivalents. Now, at the time, we made a decision that we would go out to advertise before we were awarded the monies, which we did, and that gave us 0 vacancies because we already had a vacancy factor within maternity, and so now we're actively out for recruitment for the 13. There is a jobs fair that is on next Friday, and we're part of that, and we have done that year on year. We've recruited a number of healthcare support workers to the bank. We've now got a rolling advert out for healthcare support workers. We've actually got 392 on the bank, and I've looked at a bit of the data, and in the last 3 months, only 189 of those have actually done some work with us at the trust. So I think when you look at the CHPPD, we know that we are not filling our gaps on our rotas over the last couple of months, which we sort of touched on earlier with Joe. We do offer the healthcare support workers to become substantive. So 20 of those have taken that opportunity, and we're working through where they're going to be placed within the trust. I wanted to mention about Birth Rate Plus, the interpartum acuity tool. So not to confuse it with the Birth Rate Plus tool, which is a retrospective look at staffing and capacity to give you a model for your maternity unit. This is actually an acuity tool that will be run alongside that, so that we're not just looking at things retrospectively, it's real time, and it's been a proven model that this is a really helpful way of understanding your staffing levels. It fluctuates so rapidly in maternity, depending on women coming in and what's happening, and so that is the dynamic that is maternity. So establishment reviews, we've almost finished those, and I bring back a paper to the November board just to outline what the establishment reviews have shown. I think with the increase with the changes with the band 6s, the junior sisters and charge nurses, it does present us with an opportunity to change our model and think about the nursing associate role, which is 2 years in, and whether we need to review how many band 5s are on each ward and actually substantiate that role on every ward area, and that will be part of the paper. One of the things that we were concerned about because of the number of staffing challenges we've had over the last few months was whether it's a balance of encourage people to have annual leave, but have we actually given too much leave? But actually we reviewed all rotas, and they came within the parameters that are set, because we wanted to make sure that we weren't just giving lots of annual leave and then that had tipped the balance for the staffing. The Safer Care tool we are now in the embedding stage, and we are starting to use that in the safety huddles throughout the day, and that's been really helpful to understand where our areas of concern are. The agency graph is there, and then just to really highlight that we've fantastically as Milton Keynes University Hospital, we've been shortlisted in Team of the Year award at the Nursing Times Workforce Awards, and that's a collaboratively joint entry between ourselves, workforce and nursing. And this is related to the bespoke induction programme that we did for healthcare support workers, where we brought healthcare support workers in that hadn't previously had healthcare experience. So we brought 60 in quite a rapid time frame. And also I think the interest in the collaboration with the Prince's Trust, which I've talked about previously, and a huge amount of work went into that, and it has been very successful. And we've got some fantastic healthcare support workers that have come with some really diverse experience. And I think what it's demonstrated to the organisation, there was a level of nervousness about people that hadn't had healthcare experience in the past, that actually the richness of what that can bring has been fantastic actually, and so we're very keen to go out and do a similar programme. Happy to take questions.
Thanks very much, Nikki. Any questions at all? Helen.
Nikki, thank you for the report and for highlighting some of the great initiatives that is to come place, and I think we could begin to underestimate how much work's involved in this, and the minute by minute, nay, day by day effects of staffing. And I'm just interested in the 2 questions. One is around the bespoke recruitment plan for maternity. And is that 13 whole-time equivalents, are they purely midwives? Or is there an opportunity, coming back to Joe earlier about innovation, doing things differently, and I'm conscious that this is a nursing report, and I'm just wondering if there is any opportunity to do something different. I'm sure you are, but we allowed health professionals, doctors, that sort of thing. And my second question is around actually as being part of an integrated care system, have we got to the position that actually if we're really struggling in our particular speciality or area, is there an opportunity yet to transfer staff or patients, or how does that work presently?
Thank you, Helen. So recruitment for maternity is actually 3 whole-time equivalent midwives. That was the money that was given to us from Ockenden alongside the appointment of an obstetrician. So within maternity, we have asked them as an exec team what they need in order to be supported, because even if we went out for 30 midwives, there isn't the midwives trained in order to undertake the roles. So what we've been doing actually is we've been piloting having registered nurses on the postnatal ward that have surgical experience. And actually, I think initially there was a hesitance from the midwives, but actually now when they don't have one rostered on, they want to know where they are, because they've really helped. If you think about what Eleanor was talking about, the enhanced recovery, they've really helped from the surgical perspective, our section ladies and wounds and things. So they really are supporting that. So we've asked the head of midwifery to do a review about what that might look like. We have to be mindful that the Royal College of Midwives aren't supportive of registered nurses within maternity. Regionally, the regional midwife is supportive in that we have a across the system, every organisation that is trying to recruit midwives, and we could keep trying to do the same, but we have to look at the model. So we're looking at the registered nurses absolutely add value, and also there's the nursery nurses. We could look at increasing the nursery nurses, because then they do that supportive piece. And I think there's always a level of nervousness when you've got a professional group. They don't want their skill and competence to be diluted. But I think on postnatal, there's definitely a place to do a different model. There was nationally discussion pre-pandemic about maternity associates, a bit like nursing associates, but that is fraught with all kinds of, it's controversial, I would say. But yes, we're trying different models. And actually what we've done as well, we've changed the way the specialist midwives work. So there's a group of specialist midwives that do lots of different things, mental health, all sorts of things. They are now doing clinical shifts as well. And I think initially there was a resistance to that, but actually now the team working is much better. And I think there's a general understanding of the pressure that often postnatal is a very fast turnover. When I've spoken to the registered nurses, they can't believe how quick that runs in a day. You could have 3 or 4 people in a bed in a day. So I think there's some other operational things that we could do and be more efficient. I think it's, it's sort of multi-complex really. So that's the maternity response. Integrated care system, I'm not sure we're mature enough as a system to do the staff sharing as yet. I think there's lots of discussion. So the local maternity and neonatal system, and we've shared some support with each other when we've got different complexities in different parts of service and how we might support that, and we have discussions, and I think there's joined up conversation. I don't think we're mature yet as a system to then say, could we have shared roles? But I think I could absolutely see that happening.
Nikki, thank you for that really comprehensive response. Thank you.
Thanks very much. And I think it's a sign of the times as well, the ambition, looking forward around how we know nationally, we need to make the most of staff and give opportunities. So being innovative and offering new opportunities is absolutely the way we need to be thinking. Thank you very much for that. No other questions. We'll move on then to the workforce report. Danielle.
Okay, thank you. So a few highlights from the paper from me. Vacancy rate continues to bubble along at around, it fluctuates from below and just above 10%. So we're still working on clearing as many people as we can, as quickly as we can. As we know, there's lots of new roles and new demand coming through at the moment, given the busyness of the hospital. So recruitment team are just about managing to keep up to that. Still working on reducing the time to hire, which we hope every day we chip off the time to hire is a day we get someone in post faster. So lots of effort going into that. Statutory mandatory training percentage remains high. Appraisal percentage annoyingly dropped below 90% this month, but the team have just done the figures yesterday afternoon for the latest set of figures, and we are over 90% again. So little dip, but back to the green again, which is good. Staff survey, just finalising the questions and how we're going to group them together this year to make sure that we can get the maximum data for the departments, because if there's only a few people in the department, their data gets amalgamated with lots of other departments. So we're looking to provide natural groupings this year to provide a richer data set. So that will be a good and positive change for us. And our Living Our Values work continues, as Alison said. That's been very well received, and we're taking the learning from that now and agreeing what our next steps will be and how we'll embed that in our policies and processes. The Inclusion Leadership Council, the date is in the diary for that first meeting, and we're having a pre-meet in September so that people on that council can understand what's going to be expected of them and how that's going to work. So that's another good piece of work that we've managed to get going again. Some key changes in staff for us. So our head of staff health and wellbeing, so occupational health, has stepped down, and we have, as an interim basis, had a member of the team step up to take the lead on that while we review our options for occupational health across the trust and across the system. And we've been successful in recruiting to our 2 ED&I posts. So if you remember, we had Judith, who left us earlier in the year. We've managed to recruit into those posts now. We added some money to create 2 posts, and so that's really good news, and they've started this week. And both gentlemen come with a wealth of experience in the arena, so we're really lucky to have them. Finally, the pay award has been implemented. That went into the pay system over the bank holiday weekend, so staff will receive that in their pay in September. And one last point for me, not in the paper, but around the vaccine. I know there's been lots of talk around the vaccine and booster programme, whether that will include healthcare staff or not. We are formally awaiting the JCVI guidance, which is the committee that governs how the vaccine should be given and who by and who to, etc. There is an expectation. We think they're probably going to say that we should give the booster to healthcare staff alongside the flu booster that we have every year, but we're awaiting the final guidance. Participating in lots of regional and local meetings around that. If we do need to give a booster to healthcare staff, we've agreed that we will give the booster to anyone working on our sites, whether they're SCAS or ELFT or Seem to Be Well, etc. So a real joint working effort across the patch. And I know some people have asked me questions around the requirement for people who go into care homes to be vaccinated. We do have some teams that go out to outreach into the care homes. We have a really good vaccination uptake rate here at MKUH, so I'm not too concerned about us being able to comply with that. I'm sure we will, but we're just confirming that for every member of staff who goes out into the care homes. So that's it from me. Happy to take any questions.
Thank you very much, Danielle. Any questions from anybody? Nikki McLeod.
Sorry, not a question, Danielle, but just to say I was really pleased to see that the two EDI leads have been appointed and started, which was pretty rapid work, really. Yeah, really looking forward to seeing some outputs from them. So that's great. Thank you very much.
Yeah, absolutely. Yeah, there's very good news, and I'm looking forward to being involved in the Inclusion Council as well. So I must check with you with the dates, the September meeting. But thank you very much for that. I just had one question actually. Well, no, one comment is really impressive around the mandatory training levels. That's fantastic. And my only question was around temporary staffing cost. The other areas have targets. I wonder, do we have a target for that? I mean, it may just have dropped off this one.
So I think we do on the performance scorecard. It tends to be a financial value rather than a whole time number of people. Right. But I'll check that. Okay, lovely. Thanks very much. Okay, thank you. That's noted. Thanks very much, Danielle. And we'll move on now to the performance report.
Thank you, Alison. So as Joe commenced at the beginning of the meeting, telling you how tight everything feels and busy at the moment, activity, clearly this report goes back to July, which takes us back to the beginning of the summer holiday. Seems a long time ago. And at that point, let me just say the indicators, as we've talked about, were continuing to go up in terms of the sustainability section on Objective 5. So our GP referrals were increasing, our A&E attendances were increasing, general upward trend that we've been tracking this year and has continued to do so. So the impact of that on our key targets given in section 4, Objective 4, clearly is a fairly red position where the position is deteriorating. And again, Joe referred to the sort of elective waiting times. But I think to talk about the emergency pathway as well, we see then a gradual delay and erosion of the 4-hour performance in ED, or we also see longer patient waits happening across ED, which is associated then with greater ambulance handover challenges, which again, the performance of which is not where we would want it to be. But as I've described here, again, previously, the separation in the department of having red flows and green flows and separating your staff in and amongst a footprint which we haven't really managed to expand, but we've tried to still see more patients in physically, remains a challenge. And I think, as we've also alluded to coming into that, then the staffing challenges over the summer have been difficult. In one hand, we've absolutely supported and endorsed the well-being of our staff and encouraged holidays. We've probably seen, well, we know we've seen a lesser uptake in bank and agency spend, therefore that indicator's looking better balanced, but actually on reflection, when you're letting people have the holidays, our numbers have been more difficult and more challenged. In terms of how that converts into our sort of clinical effectiveness, I think our challenges then remain around how we operationalise some of our daily processes, but we do remain challenged, and it's almost single-fingered numbers that we're managing to see discharges out before midday. the numbers across the ward, certainly more so in recent weeks, but it has been evident across the summer, processing those discharges, those super-stranded patients, and getting that level of engagement is there, but the effectiveness and the pull from the system and community, again, they are challenged from a pressure point of view. So the emergency pathway, whilst when you read the report, we still seem to be faring particularly well against peers. And when you look at the numbers, I think we all know, hand on heart, patient experience that we're delivering could be better. But again, set in a context which is very complex. And as I say, then from a planned elective care point of view, we experienced a 5-week kind of loss of one of our laminar flow theatres, which took out elective capacity. And as a result, the cancelled operations on the day in this month particularly were affected, because we started at the beginning of that month very much trying to do the best for our emergency patients and our elective patients. In reality, we had to succumb where we gave up the elective bit, but we were for a beginning of that period trying to keep both flows running. And I think that's really the explanation behind the cancelled ops on the day increase. The cancer performance, again, unfortunately, as a sea of red indicators, the 31-day performance in month was better. Again, I would just add to the caution on the 62-day standard, a drop in performance would also see a greater number of people being treated who had breached. So we were effectively treating the long waiting patients and getting through the backlog. The recovery position is on track, although we have some challenges clearly with our imaging capacity at the moment, and John and I and the team working hard to resurrect more MRI and CT capacity. As you'll understand, they're pretty big objects to bring onto site, as well as deliver our improvement programme in what we're doing for MRI. So we've fortunately had some more money in the last week that we hope to spend again on more MRI capacity. It's a little bit of a jigsaw in terms of getting mobile units on site and multiple mobile units on site, as well as delivering our operational activity. That said, the ability of bringing those operation modular machines in on site does come with staffing, which relieves the pressure. So if we can get that organised, I think our recovery into diagnostics will look better. I'm happy to take any questions at that point.
Thank you very much, Emma. It's really helpful. Huge pressures in the system. I mean, and as you and Joe have both highlighted. Just one thing I suppose I'd just like to ask really is around, obviously one of the key planks for people that I think nationally people understand about the backlog and having to wait, and you know the pressures on emergency versus elective. But in terms of our communications with patients, because I think that's one of the key planks around managing people's anxiety as well, is that they're kept informed. I mean, presumably we have a sort of system where, you know, we give regular updates to patients.
Yes, we do, and we try and maintain those communications. I suppose the impact, though, of having sort of theatre downtime meant that we have been chopping and changing, so that dialogue probably doesn't look as smooth as it could do in terms of planning, but you try to react to getting patients in even on a short notice period and picking it up. I think from the outside looking in, there will be some patient experiences will say, you know, you didn't give us much notice, but that is also us trying to maximise the capacity when those unexpected events happen, and we have to work around in that. But communication remains paramount with our patients. Yeah.
Thank you very much. Thanks. Nikki.
Thank you, Chair. It was just really to come in around the communication aspect. So the advanced nurse practitioners in cancer, they do track all the patient pathways and they do patient welfare checks, and they can refer for holistic support and to their health and wellbeing centre if there's any concerns. They also have a helpline. It is Monday to Friday, 9 to 5. Which obviously, you know, we would like it to be longer and over the weekend, but there is a way of contacting and raising any concern, and that is given to them. The GPs also have patient information leaflets which describe the service. So there is a number of ways that they can seek advice if they can't necessarily, if they've got concern.
That's great. Thank you very much. And Luke.
Thanks, Alison. It's just a quick question around the cancer targets, really, and whether you've got any more detail on how they compare. Realise they're below target, but how they compare both within maybe the ICS and more nationally?
So actually our Thames Valley performance is doing very well. So we are above, and we've been supporting other centres throughout the COVID period in terms of our pathways that we adopted and some of the alternative routes, as Nikki said, not only the communication piece, but the treatment options that we adopted. So I'm very confident, Luke, that we're doing as best as we can, in relation a little bit like A&E performance or the 4-hour standard. However, I think all of us challenge ourselves when you see 104 patients in ED on a Monday night, and that's remained consistent. We've been in Opal 3 for nearly a week now. We've not been able to de-escalate at the moment, which I think, you know, in long-term memory is unheard of, but reflects the system position as well. Our cancer performance is up there, but again, I think compared to what we're used to and the high expectations we're setting ourselves as a board and for our patients, we want to do better.
Thank you. Thanks, Emma. And Helen.
Hi, Emma, just quickly, I wanted to ask about the super stranded. I don't think I'll ever get used to that name, but the super stranded patients. And I know it's only a small increase from 70 to 73, but that 73 beds, I'm quite sure, would make a huge difference to the already tight bed capacity. And I know it's really complex and it's difficult. But I just wondered around the support. As I say, that 73 beds I'm sure would be very useful. And I'm just wondering about how you're being supported to help, you know, move these super stranded patients. But as I say, I do appreciate it's complex. But yeah.
So I think to give you a bit of detail within that cohort, Helen, a number of those patients are tending to fall into out of area, so not within our direct control locally that we can pull on the system. And that always presents us with more, when I say time consuming, but it's just an elongated pathway, building the relationships with the people that we don't normally know and work with routinely. So that's one impact. I think from a system perspective locally in MK Place, we're working very well. And partners clearly challenged. I know some of the community care and primary care the community care facilities have also had the challenging staffing issues. We, as have community, have often had the gaps in the therapy staffing, so all those key components and roles that absolutely help us pull that through have been hit. And it's no excuse, but you're kind of prioritising on a day-to-day basis. And where in the beginning of COVID and the first surge, we emptied the hospital and everything was running very cleanly. And I think the expectation was we continue to do that. Clearly, primary care, community care had to go back and reinstate all their services. And as a result of that, it has slowly drawn the responsiveness as they brought back their profile of services that they should be running. But in response to your supportive question, you know, we still work well together. We have regular meetings. The escalation calls have happened every day this week. We are still talking and continuing to set up made events going forward with community partners. And I think that interaction and having more people in reach into us across the social care, healthcare partners continues, but challenge to us all, I'm afraid.
Emma, can I just ask a subsequent question around the outer area placements? Are we speaking about big numbers there as part of the 73?
It's a handful within there, so you know, it's again moving picture, but some of those are complex ones. Again, it doesn't tend to be the super stranded patients that fall into the mental health, but we have had a number of patients who've been with us. There's an ongoing conversation across the east of England around the mental health capacity. Now, I'm not suggesting that that's stranded and super stranded. We initiate those case conferences on individual patients as we see fit.
Thank you, Emma.
Thank you very much. Nikki.
Just wanted to highlight to board that there is we do have an emerging issue as well with some of our care homes who are insisting that patients are double vaccinated. So we've got a few patients in the hospital that aren't, and that is a real challenge. So we are vaccinating patients if we're able to, but because there's a huge drive in care homes and nursing homes for the staff to be vaccinated and the patients. So that is adding another complexity as well, which is not great for the patient. for them not to be able to move. So it's just to raise that really, because that is a bit one of our concerns as well. Obviously, we're in discussion with that with the CCG lead for infection prevention and control, but obviously that does add another dimension.
Yes, I think it's pretty clear that that area, the complexity of what everybody's dealing with is a huge challenge. So thank you all very much for the work you're doing. It's a constant, isn't it, really? Okay, we need to move on then onto the finance report. Karen, are you picking up on this?
Yes, thank you, Chair. So you will have noticed that in this time's report, we actually have a new star finance report, which starts at page 40 in the pack. The aim of the report is to give some succinct key information. So you'll notice that at each sort of page we have a key messages box, which sort of highlights the key messages for that particular section. So I'm going to start at page 41 and reference in the main table as row 7. So the Trust is reporting on a controlled total basis a year-to-date deficit to the end of July of 830,000, and this is 77k adverse to plan. As a result, the Trust is forecasting a deficit for the first 6 months of the year of 1.28 million, which is 150k adverse to plan. In the month of July, there is a deficit position of 397k, which is 177k adverse to plan. So up to the end of July, the Trust has included 4.5 million of ERF income, which, as you know, is associated with elective recovery. This is actually 1.2 million lower than expected. And as Emma has talked about, we have had some operational issues. We've also had a high level of annual leave. And I think, as Terry mentioned at the last meeting, the threshold for ERF has increased from 85% to 95%. As a result of this, we've seen increased pressures relating to pay and non-pay associated with this additional activity. I'm moving on to row reference 11. So the Trust continues to have high cash value, which is around 48.4 million, but the Trust continues to track above the 95% for its better practice payment code. In respect of the capital programme, this is starting to progress, and we can see up to the end of July we've spent 3.5 million against a plan of 4.7. Included in the plan was our aspirations around the new hospital programme, so that is actually accounts for 0.8 of the difference for the July plan. Moving on to just talk about sort of H1, we're still awaiting guidance for the funding for the second half of the year. That should be coming out imminently, but we haven't had the detail on that. Efficiency expectations have been talked around about 3.5% for the second half of the year. That's all I was going to report on the finances, but I'm happy to take any questions.
That's great, Karen, thanks. And just before anybody asks any questions, I have to say I do like, I hope colleagues do as well, but I do like this new presentation, and it's so handy having those key messages coming through. Really, really helpful. So yeah, very happy for that to continue. It looks, I can see lots of nodding, so I think others find it very helpful too. So thanks for that.
Thank
Helen.
you.
Yeah, Alison, you beat me to it. I just wanted to say, wow, what a difference. And for somebody with a non-financial background, it was fantastic. And I found the key messages, the summaries, really helpful. So well done to Terry and the team. And I have actually emailed them because I was so excited and about it. And as I say, it really made sense to me for somebody that, you know, should have tested on really, because no financial background. Really understandable. Thank you very much.
Thank you, Helen.
That's great. Thank you very much. I think the report's very clear. Does anybody have any other questions or comments on this? No? Okay. Thank you very much. Well, that's received, discussed and noted. Thank you. And we're going on now to item 12, Milton Keynes radiotherapy. Joe, over to you.
Thank you very much, Chair. I'm just wondering whether I should do this or John. But if I start, it's been long our ambition to get a radiotherapy centre here at Milton Keynes, to the extent that we actually split the development of the cancer centre from the radiotherapy unit because we wanted to get on and deliver something at least. The paper that we have here is setting out what we would like the board, the steps that we've been through, including getting national and regional sign up to this, and we now are looking for the board to receive the case and progress to the next stage. So John, do you want to come in on that point?
Sure, Joe. Yeah, so this sets out the where we've come from. The decision about placing a radiotherapy building sits with the NHS Specialised Commissioners, and in this part of the world, their life has been further complicated by deciding the future of the Mount Vernon radiotherapy service as well. But recently, this has been clarified, and it looks as if all parties have agreed that a single linear accelerator at Milton Keynes is the best way forward. We've had some really good conversations with Oxford now about solidifying this into a workable scheme. The trick now is to find all the necessary money to build the centre, and we have made significant progress. So this is, if you like, an update report of where we are. We will have the beginnings of an outline business case in the private part of the meeting coming up, but we're very hopeful that within 2 or 3 years we will have a working radiotherapy building in Milton Keynes. I'm very happy to answer any questions.
Thank you very much. Thank you both. Very clear paper. There's obviously been a huge amount of work as well going on over a period of time. So it seems to be a very positive move. Andrew.
Yeah, just to say the same thing. It's encouraging progress, and all the best for progressing the plan.
Thank you.
Yes, good stuff. And I think in terms of, I mean, we've been talking a lot about patient experience and things today. So I think this is a very positive move, frankly. So look forward to further discussions. And I think looking around, there's no other questions or comments. So yes, the board is happy to. Oh, John.
Only to say, when Joe in his chief exec update began to mention the Macmillan Quality Environment Mark, MQEM, I was going to do it as part of the outline business case, which actually is in part 2. So I think we ought to formally note that Macmillan have awarded us their MQEM mark for the cancer unit. We received 5 out of the possible 5. It's a tremendous achievement. And just to remind people that we lost this mark with our previous cancer centre, where we originally had it when it was built, the old MAC unit. But a number of years ago, they came in and stripped that away because the environment had slipped for patients. So this is a really great achievement for the cancer team.
Absolutely, that's fantastic. Thank you very much for bringing that up. Yes, and well done. I mean, obviously this all happened before I arrived, so it is very impressive. I've had a quick look at it. I'm looking forward to going back and looking at the centre again. But and talking about these radiotherapy services as well, of course, that will be an additional plus to the services overall. So thank you for that. So we note, and we look forward to taking that forward in later discussions. Thank you. Going on then to item 13, cardio cath lab.
Thanks, Alison. So again, aspirations of further developing services and replacing some of the old kit. This really is just to notify the board that the medicine division are looking to replace their cardiology C-arm, which delivers their angiography service. It's 15 years in situ. time expired, essentially a much better patient experience, which is described in the paper, and actually reducing their radiation doses as new equipment comes online and technology will also be of huge benefit to our patients. That refurb in itself comes in around the 950k mark currently. The business case is being written, but we're notifying the board because at the same time we will look to also purchase and install the equipment related to the PCI repatriation of patients that's coming back from Oxford, which again will develop our services here on site. With that combination, we'd be looking to ask the board for delegated approval to FIC that we take that business case through their in due process. But it was really just giving you an indication of some of the work that's going on in cardiology and medicine. I'm happy to take any questions on that, but hoping everyone's supportive.
Thank you very much. Joe.
I think it's just a highlight to the board really that both the radiotherapy centre and also the work planned around the PCI service are being done with the support of Oxford. So Oxford, in the case of being a recognised cancer centre, and on cardiology being a recognised world leader in cardiology, not just Europe or the UK. They have got one of the world's best cardiology departments. And for us, it is about having that sort of big brother relationship with Oxford that allows us to develop and grow appropriate services locally until such time as we reach a certain scale, which will be in many years, that we can stand on our own 2 feet. But I wouldn't want the board to think that we were doing this in isolation of very robust governance arrangements, either of these services, without very robust governance arrangements from a centre that is very well recognised.
Thanks, Joe. That's really helpful clarification. Luke.
Yeah, I was just going to add to the cath lab proposal, just hugely supportive, I think, from customer experience perspective, but also clinically, so time to intervention for the residents of Milton Keynes, hugely important.
Thank you.
Yes, thank you for that. Yeah. So I think, yeah, everybody very supportive of this, and quite rightly, as you said, Emma, it's you know, it needs an update now, and in terms of age and things. So do you need an approval at the moment or agreement at the moment for the delegated, or is that coming back next week?
Yes. No, if we could seek the delegation approval here, then we'll take it through FIC.
Absolutely.
As the work continues.
Colleagues happy with that? Yeah. So we can approve that. Thank you very much.
Thank you.
Item 14 then, significant risk register.
Thank you. So significant risk register report is here for information. You might notice that the significant risk register has condensed quite significantly since we first started looking at it at the board particularly, to a much more manageable size, and that's because we're using divisional risk registers and risk scoring much more effectively. I think through the trust. We've got quite a big piece of work going on at the moment in risk management, and that is the transfer of our risk incident management systems from one system to another. So we bought a new system called Radar, which will replace our Datic system, and that work is ongoing at the moment. So all of our risk reporting will start to look a bit different because it's a different system. It's and hopefully will be a positive move and step for users. Otherwise, apart from that update, happy to take any questions on the substance of the risk register.
Thank you very much. Andrew.
So not a question on the substance of it, well, indirectly. There's a risk there around some old mammography machinery, and although I wasn't, and it's quite well documented in that line as to how that's being dealt with and how we're, but my broader question is, given we've got business cases around older equipment, and we've just been talking about older equipment, what's our overall exposure to elderly equipment across the trust, and is that something that really should be would that be a risk that might justify being escalated to the BAF? So a broader question about our obsolescence or worn out gear, please.
Thanks. Joe.
Thank you, Alison. A couple of things. One is that I think we are relatively No, I think we are unique in having the medical director chair the capital process for our organisation. And we have the divisional directors around that table, as well as estates, IT and others. And so I sit at board confident that our capital allocation is taken through the lens of clinical risk associated with breaking equipment, any concerns with patients. So that's the sort of first thing to say. Second thing, the finance team have done a fantastic job over the last few years in getting appropriate asset registers and an understanding of the actual life of bits of kit in the trust. The final part for me, and then I'll hand over to John, is that we also keep a relatively sensible contingency fund every year, which does get used for bits of kit that break unexpectedly throughout that period of time. And when it's sort of £80,000 for an X-ray tube, you can't just close down X-ray. So we do keep a contingency fund for things that come along unexpectedly. But I don't know if John wants to add into that.
Thank you, Joe. Just on the particular point about mammography, we were notified yesterday at the Trust Executive that the third, so this is a brand new third machine has come online, and for the first time it's a tomography machine, so it's able to do three-dimensional imaging of breasts, which was a missing from our armoury, so that's very good, and we do have expectations of replacing the other two machines. I also completed an FOI request actually on the number of imaging devices over 10 years. We've only got, of all our ultrasound and imaging devices, we've only got 2 devices over 10 years old. So actually we're very, very well placed compared with many other trusts.
Thanks, John. Joe, you wanted to come in?
Yes, sorry, there was one final bit which I think really should give the board assurance, which is that the divisions absolutely recognise now, it's learnt behaviour, it's been happening over many years, that if they do want to update or renew a piece of equipment, if it hasn't appeared on the risk register or it's not appropriately referenced on the asset register, their chances are much slimmer. So we have trained the organisation to use the appropriate governance processes to flag when these things are coming on. It's taken, don't get me wrong, it's taken years, but I'm much happier than where we were 5 years ago.
That's great. Thank you very much. Thanks. Any other questions? No. That's great. Thanks very much, Kate. Just sort of couple of notes just on some of the timings. There are some timings missing in terms of the completing the columns, and also there's around the lack of awareness of asbestos potential. There's the impact column hasn't been, so if those could be added to, that would be really helpful, because then it gives us a complete picture. Thank you very much. The board assurance framework, that stays with you, Kate.
It does. So the board assurance framework, again, here for information. I don't think, unless Kwame might come in and correct me, there's been any significant changes to the board assurance framework in the August reporting month. Clearly, as we've discussed, some of the risks here around operational pressures and growing operational pressures in both emergency and elective care, and those remain on the board assurance framework. So no significant changes to document.
Thank you very much. Anybody want to raise anything there? Okay, thank you very much. So that's noted. Then we're going on to the terms. Oh, sorry, Hader.
Sorry, I was a bit late putting my hand up, so I apologise for that. Just on the BAF, page 84, risk 4. I was wondering if that should be removed now. Doesn't look like there's much happening of that. I'm going to go and find it myself. I guess a more general question is, how long do these risks stay on before they get removed? What's our threshold for removing risks?
So I think they need, so it should be, they are reviewed with each director every month, and if the risks, is at a tolerable, manageable level that's no longer threatening a risk to the achievement of our strategic objectives, they should then de-escalate from the BAF and go on to the corporate or significant risk register as appropriate. I think you talked to risk for around digital change programs. That's the one you're referencing.
Yes. Yeah.
So I think given the rollout of e-care and the impact of post go live, it probably should be on the BAF for a little while, even though it's being really well managed. So I think although it's a low risk because it's got a really good management and control framework, the risk is probably still fairly present for us as an organisation, and the potential is there for that risk to grow again.
Okay. There was another one on cybersecurity that I think we discussed briefly last time, and that seems to be going up. I can't remember if it's gone up since our July board meeting, but it's the trend is continually rising. Sorry, I'm trying to find where that was. I think it's quite far to the end. I guess one of the reasons I'm asking the questions, it would be great to focus on a couple of key risks and actually have a discussion around them, things like cybersecurity, whereas the digital change program seems to be, as you said, running really smoothly, which is great. Obviously that might not have been the case had phase 3 not gone so well. So I guess just a general point, not
I think it's number 14, Hader.
Thank you.
Number 14, right. John, your hand went up. Did you want to come in on these?
Yes, please. So when Kwame and I last discussed the risk 4, we decided to keep it on until after this phase C, because this is probably, I won't say the last, but it's probably the last for quite a long time of quite big engagements with the hospital. And so I think probably in next month or the month after we should take this off. In terms of the cybersecurity, the risk went up because over the last couple of months there's been quite a lot of external activity, and we felt the external risk warranted increased rating. But nothing has changed internally. I think internally we're still regarded as being exceedingly good by NHS standards. But because there had been so much activity and various hospitals had experienced attacks, that it was sensible to increase the risk.
Makes sense. Thank you, John. Just one last question from me. Page 96, there's a risk around patient experience, and one of the sources of assurance are quarterly reports with themes and areas for patient improvement. I was just wondering if we could have a deep dive on that, perhaps at one of our next board seminars. Thank you, Chair.
Thanks. Well, yeah, I'll take that up with Joe around. There's quite a bit of work going on. We have talked about more discussions around patient experience and things, and certainly I'm looking forward to sitting on one of the patient experience boards. It had to be postponed, I think, in August, so we're picking up with that soon. So we can come back to that, Hazel. Thanks.
Alison, can I just say that patient experience is a role and agenda item in our Quality and Clinical Risk Committee.
Yeah. Yeah, no, good point, Helen. Absolutely. But it's yeah, certainly something I'll have a discussion with Joe, because it's probably something for a board discussion at some point in the broader sense. So thank you very much. Okay, so that's noted, and with those comments, then well, agenda items 17, 18, 19 and 20, there's summaries here for information and noting, unless anybody needs to pull out anything to flag up with us particularly. We can take those as read. Yeah, Andrew.
Not a question, just to know, I like the new report formats. I think that's easier to digest. So whoever's prepared those, thank you.
Yes, yeah, it is very handy. It's very handy having the key things highlighted. John.
Unless I've been asleep, you might have skipped over the terms of reference, item 16.
Do you know what? Yes, you're right, John. I did, and it's because I ticked them off too early. I do beg your pardon. I'm jumping ahead today. I'm obviously very keen. Yeah, we go back to the terms of reference. Obviously, everybody will have read those, and with the amendments, everybody happy with those? Yep. So those have been approved. Good. Thank you very much. Noted. Thanks for that. Then going on to 17 to 20 summary. Everybody happy to note those? Yep. So that's agreed as well. I haven't been given any notice of questions from the public, Kwame, unless there's anything that you've got. Don't know. Is he there? No, I don't think so.
No, nothing came through. Nothing came through. No.
Okay. Thank you very much. Oh, Kate.
Sorry, just because of a quirk of timing, we haven't got the reporting instance and learning report at this board. It goes to the Quality Committee on the 20th, so a week on Monday. What we'll do is publish the Quality Committee report to the website just for transparency's sake and to keep up with timing. So there is a report published in September that's transparent around our instance and learning for that reporting period, so we don't skip 2 months to the next public board.
That's great. Thank you very much. So on that note, then we're well done, everybody. We managed to make up time. We've had some good discussions, and presentation this morning I think was absolutely fascinating. So it was well worth having that extra bit of discussion around that. So I'm now going to bring this meeting to a close, and we have our private board starting at 12:10. I think it is time for people to have a bit of a break. Joe?
Sorry, just one thing. I don't know whether we've formally raised the issue about the annual members meeting and the change of date requirement.
Yes, thanks for the reminder. Yeah, absolutely. There was an issue around the presentation of the audit of accounts and presentation that's still got to go to Parliament. Is that right, Kwame, I think? So we're waiting for confirmation of dates for that, because we can't have the annual members meeting until that's all gone through. It's all the governance issues need to be closed off before we can. So we will announce the annual members meeting as soon as possible once we've had some clarification. Thanks, Joe, for reminding me of that. I'd forgotten to make a note. So unless there are any other points we need to note in our public session? No. Okay, well, thank you all very much. And thank you everybody who's been attending and looking in today and listening to us. And I'll see colleagues again at 12:10 once people have had a break. Okay, thank you very much.